Okay, so I'm very pleased to introduce several presenters who have expertise in substance use disorders in older adults. Dr. Adel Mazanderani, I'm going to pronounce this wrong, Mazanderani has served as chief during his family medicine training. He worked as a primary care provider for 3 years when he was involved in initiatives to integrate evidence-based treatments for chronic pain and substance use disorders in primary care settings. He then completed a fellowship in addiction medicine at the University of Washington before returning to practice as primary care provider. Dr. Joe Merrill is a professor of medicine at the University of Washington and Harborview Medical Center, and he's board certified in addiction medicine, has extensive clinical teaching and research experience in addiction medicine and the management of chronic pain, particularly related to chronic opioid therapy. And Dr. Mary Davies graduated from the UW Internal Medicine residency in 2021. She's board certified in internal medicine and currently completing an addiction medicine fellowship at UW with a focus on treating substance use disorders in primary care settings. So you can see we have some tremendous expertise today to talk with us about substance use disorders in older adults.
Awesome. Should I start?
Yes, I'm
okay.
ready for you.
I'm so sorry.
And you're coming in great. Thank you.
Yes. Okay, good. So hi, I'm Adel Mazanderani. Thanks for the introduction. It's an honor to be here. Okay, so I'll just start. So Dr. Merrill, myself, and Emily, we have no conflicts of interest. So learning objectives, I'm just going to tell you the objectives for all of us, but I'm going to focus on part 1, where I'll talk about general concepts. And with that, I want to make sure that by the end of this presentation, you guys can have a good understanding about the trends in alcohol and substance use disorders, also knowing about the risk factors and the protective factors, and being able to identify some of the signs and symptoms of substance misuse. And finally, also understanding that screening for mental health disorders is a key part of this. Part 2, Dr. Merrill will talk about alcohol use and talk about the screening, assessment, and consideration for pharmacological treatments for unhealthy alcohol use. And last part will be on opioids. We'll talk about the assessment and management of prescription opioid use, including assessment and treatment for opioid use disorder. So next slide, please. Yeah, so understanding the issue, I want to make sure we have an understanding that the number of older adults with SUD is increasing. The baby boomer population, their outlook and their exposure to substances growing up is much more than the previous generation, and the baby boomers they're increasing in our population. So it's not surprising to see a lot of patients, geriatric patients, who have experimented with substances or have struggled with substance use disorder. The older adult population is also becoming more diverse. Depending on your practice setting, you'll notice the non-white, even non-Hispanic population is increasing. So it's important to recognize that and also be able to adapt your practice for that patient population. Third point I want to make is that substance misuse among the geriatric population can increase the risk of death and other physical harms. This goes back to the theme of the increased sensitivity that geriatric population can have to substances and medications in general, with the physiological changes, reduced water content, muscle mass, increased fat, and organ issues such as heart disease or kidney or liver issues. They're much more sensitive to substances, and consequently, with substance use, they can have risk of overdose, risk of cognitive impairments, sleep problems, and those are things to keep in mind. And also, substance use disorder in general is underdiagnosed in the older population, and that's one of the things that we're going to talk about today, those subtle signs and symptoms of substance use in the geriatric population. So next slide, please. This is just a graphic representation of illicit drug use by age. And in general, as you can see, the 50 to 69 and the 70 plus years population, their substance use, and this is just illicit drug use, it's actually increasing. There's a recent study, JAMA, it was published last week actually, that also showed how the trends are increasing for the geriatric population, patients 55 and above. Right now, compared to 1990, the rate of substance use has gone up tenfold, and multiple reasons for that too. And next slide, please. This is to highlight the fact that other than alcohol and tobacco, prescription opioids and benzodiazepines are the most commonly misused substances. But also to keep in mind, there are other substances that patients may be using, including stimulants, methamphetamine, cocaine. Of course, cannabis is a significant portion of geriatric patients. They use cannabis as well. And the number of ED visits, so the problems the patients are having due to the medications or prescription medications that they're taking, it's a significant number. This is just highlighting the number of ED visits for non-prescription or prescription pain relievers, but also benzodiazepines is high on the list. So some of those things to consider, and that's increasing over time. Next slide, please. So I want to highlight some of the risk factors for substance misuse. A lot of these may come up in general for a lot of conditions. It's common theme. So social isolation, unfortunately, with the collective trauma of the pandemic, it has affected a lot of geriatric patients. And so social isolation, when it comes up during a visit, in my mind, it's always a risk factor for substance misuse. And I always try to keep that in mind. The environment, if somebody's relocating, especially with the pandemic, a lot of people have relocated either for economic reasons or such. The environment they're in right now can really affect their risk for substance misuse. Physical health, of course, as the patients are getting older, they have comorbid conditions, they have pain, sleep problems, mobility issues, so they may be at more risk of substance misuse. Mental health disorders, this is key. Depression and anxiety, very prevalent among patients who have substance misuse. So that's definitely a risk factor to consider. Cognitive decline, of course, dementia or memory related conditions like Alzheimer's, all those things are risk factors as well. Economic stresses, like I mentioned, with environment and, pandemic and such. Rising medication cost, healthcare cost, reduced income, all those things can be stressors, and that can be a risk factor that's significant. Lifetime or family history of substance use disorders, that's, of course, there's some genetics, family history is important to know, but also lifetime. Somebody had substance use disorder 20, 30 years ago, they're still at a slightly higher risk than the average population, so something to keep in mind. Availability of substances, that's something that you don't always think about, but the environment the patient lives in, and of course nowadays with the high prevalence of illicit substances that are really cheap to get, that's something that patients may turn into, and if they live in an environment that it's readily available, they may start using substances. And last but not least, retirement. When not voluntary, that's also a very important contributor, risk factors that we should consider, especially recently with the pandemic. A lot of people were forced to retire, and they may have increased stress, depression, and that can lead to potentially coping skills that are unhealthy. So next slide, please. Protective factors, try to go over this faster. Resiliency, their prior experience with overcoming stressors, that can be a protective factor. Supportive relationships, especially if they have a partner that they live with. Supportive network and social bonds, friends and extended family that they have can be a protective factor. Ability to live independently, access to basic resources such as safe housing, positive self-image, well-managed medical care, and proper use of medications. Having a PCP itself is a key factor for a lot of patients. PCP that they can follow up and they trust, they might be able to bring up the issues more. Sense of identity and purpose, and of course, retirement when it's voluntary. A lot of people are really happy when they get to retire on time as they planned it, and that's a protective factor. Next slide, please. Barriers to seeking care. I think this is a very important issue to keep in mind, especially for the geriatric population. The wisdom that comes with age is irreplaceable, and that's something to keep in mind. So a lot of geriatric populations, geriatric patients, they have their own way of coping with things or thinking about things. So that may persist even though they may have problems with substances, and they may not want to seek care. So negative attitudes is an important one. Patients or their providers even, or the family members may not feel comfortable addressing substance misuse. So that may not come up when it should. Co-occurring physical or mental health conditions. That's related to also, if somebody has anxiety or depression, they're less likely to want to talk about it sometimes, or talk about their coping skills or their lack of. So that's an important barrier. Also, not having awareness of the potential risk. So sometimes patients or the family members really don't know that, a substance, even at low doses that patient may be using, may actually be harming them. And it could be a long-standing issue that was just ignored. Lack of social support, that basically comes with the fact that patients may not have support from family, or not willing to come in for visits because they're just not willing to take that extra step, or have anyone take them. So that can be a barrier to seeking care. Accepting attitude. So what I mean by that is some people think that it's okay to drink or do the substances they're doing because they think that it's not really harming them, and that, oh, it's been like that for a while, or they don't even think about it, that it may not be acceptable for somebody to drink or use substances as they age. Lack of knowledge, that's very common. A lot of people don't realize that as we age, a lot of physiological changes happen in the body, and the alcohol or the drugs that are used may be much more dangerous to their body. Misinformation about treatment. Some people have negative attitudes about the fact that they might think that as people get older, they're not going to be able to respond to treatment, or that they're not going to have a good outcome. That's part of that negative attitude as well, and the ageism concept that, as people get older, they think that there's less they can do, or less that should be done. So that's important to keep in mind. And finally, cultural norms. I've seen that a lot with patients from different backgrounds. Some may not want to talk about their mental health or substance use issues, and they don't have that help-seeking behavior. So that's important to keep in mind as well. So next slide, please. Common myths and misconceptions. So you may hear this from patients or their family members, especially their family members, actually, was what I have on here. For example, like patients might say, my mom is only drinking to deal with her grief, and it's temporary, and that's part of that accepting attitude. She can't get addicted at her age, so that's sort of a misinformation or lack of knowledge. He enjoys the tobacco smoking; it's his only pleasure in life. And my father is too old to change. So again, that misinformation that can perpetuate substance use for patients. And also, he will never change his drinking habit. These are exact words that you might hear from patients or the family members that are around them. Or sometimes, even as providers, we may think like this for some patients if we're not aware of substance misuse and their consequences. Next slide, please. So signs and symptoms of substance use, it's important to highlight for elderly population. These can be very subtle, memory problems, changes in sleeping habits, unexplained bruises, irritability, sadness, or depression, changes in eating habits, wanting to be alone, failing to bathe or keep clean or take care of themselves, losing touch with loved ones, lack of interest in usual activities. It's important to realize most of these things are co-occurring with mental health disorders. That's why it can get really tricky to try to pick up on these symptoms, and also if they have other comorbid conditions. Now, diagnosing a use disorder, this is just based on DSM-5 criteria. I want to make sure that we highlight the fact that there has to be a clinically significant impairment that does happen over a 12-month period. before we really try to hone in on a diagnosis or try to meet this criteria. I just have these criteria here just so you know about them, and you can start to understand and appreciate the kind of questions we try to ask patients during a conversation. I'll go over these, and then I'll highlight some of the challenges of applying these in the elderly population. And also, just to give an overview, I usually break these down into 4 sections. The first 4 questions I think about impaired control. The next 3 questions I think about social or functional impairments. The next 2 I think about risky use, and the last 2 have to do with the physiological changes. So going with the first one, I'll quickly go over these and tell you the issues that are pertinent to geriatric population. Using in larger amounts or for longer time than intended. In fact, in the geriatric population, they may use less of the substance because of its physical effects. So that's one thing to keep in mind. Wanting to cut down or stop using, but not managing to, that's the same as in the general population. Spending a lot of time to get, use, or recover from substances. Effects of the substance use in the geriatric population can happen even with relatively small amounts, so that doesn't always apply. Craving, elderly may have some craving, but sometimes they don't even recognize that they have that substance craving, and it's not usually the same as it would be for the younger adult population. Next one is number 5, inability to manage commitments due to use. So geriatric population, especially if they're retired, their roles and responsibilities have changed. They don't have as much of that responsibility or commitments. 6, continuing to use even when it causes problem in relationships. And that's a subtle one. You know, patients may not realize that their substance use is actually affecting their relationships or their social issues that they may be having. 7, giving up important activities because of use. Well, most elderly patients may have fewer activities that they're doing. So that's a difficult one to know if it's actually being reduced because of substance use. Continuing to use even though it puts them in danger. Again, they may not understand that what they're using is harmful and what they're using is actually causing that issues that they're having, like the heartburn or other problems like that, like heart problems. So 8 and 9 are sort of very close to each other. Number 9, continuing to use even with the physical or psychological problems. So that's when their substance use is affecting their mood, and it may be made worse by using, but they don't realize it until they really have major problems. And the last 2, increased tolerance and withdrawal symptoms. The tolerance actually may not be increased over time. It may actually be lowered because of depending on the substance use and the physiological changes. And the withdrawal symptoms, that's also a tricky one in elderly population. It may be much less obvious and it may be more drawn out. We can actually go to the next slide, and everything that I talked about right now these are the highlights of that, you know, the considerations. So we can actually skip this slide too. This is just the highlights for you to know about the stuff that I just talked about. And this is another objective I want to make sure we highlight, that the co-occurring mental health disorders. What I've noticed most of the time as a primary care physician, when I pick up on substance use, it's really when they come in with their mental health or they want to talk about their mood or issues that have been going on. And it's very important to understand that depression, anxiety, PTSD, and trauma are co-occurring. About 37% of patients with any substance use disorder also have a mental health disorder. Those numbers may actually be higher, and we should keep this in mind to screen patients. You can go to the next slide. This is just talking, I just highlighted over here the main co-occurring conditions and how to screen for it, you know, for depression, PHQ-9, or the geriatric depression scale, for anxiety, general anxiety disorder questionnaire, geriatric anxiety scale, you can use that. For PTSD, trauma symptoms, or elder abuse, you can use any of the questionnaires. In primary care, I usually use the primary care PTSD screen for DSM-5. There's also the elder abuse suspicions index. And cognitive impairment is also another co-occurring condition that may not show up early on. That may be over time that patients may realize that it's actually affecting them cognitively. But you can do mini-cog that you can monitor over time. The Montreal Cognitive Assessment is another one. Unfortunately, I think you have to pay for that now. So there is another one that recent studies have been published that show really good validity, and that's the self-administered gerocognitive examination, the SAGE questionnaire, and that's a self-administered questionnaire. I didn't have that on here, sorry. I just saw this study last week that really validated that, and I'm going to start using it myself, actually. So that's that, and then we can go to the next slide, please. Mental health services. This is just an overview. I just wanted to highlight there's actually more than what I have on here in terms of different ways of considering treatment for patients with substance use disorders. This is not particular to any substance, but in general, even those small, brief, targeted counseling or education or motivational interviewing, that's a key one that in primary care I tend to use to try to motivate patients for changing and also thinking about the mental health disorders and seeking help as needed for them. So mutual help groups, a lot of the elderly population might like that because they get to actually, they know that a little bit more, like a 12-step facilitation groups or Alcoholics Anonymous and other groups like that. So it's just an overview, but knowing the fact that there's many options, many ways of treating patients is important. So, and next slide. This is just the take-home points. I want to make sure that we know that substance use is increasing among the geriatric population, and it is associated with negative health outcomes. You know, in 2021, there was 100,000 opioid-related deaths, and patients over age 55 were affected, and I think it was about 80% of them that were affected. So from that age population, so it is definitely an issue to keep in mind. We have to try to do our best to reduce barriers to care by providing the person-centered care, and also recognizing the signs and symptoms of substance use disorder, which may be very subtle, but they can manifest in medical and mental health disorders. And like I mentioned before, patients may come in for their medical and mental health disorders, but during your history taking, you may realize that it may be related to substance use disorders. And substance use disorder criteria may not fully apply to older adults, as I went over that. Usually it's a conversation where you try to see if they meet the diagnosis, and it's really hard sometimes to pick those out. And it may take at least a couple of visits before you get to know the whole picture and see if they actually have a true substance use disorder. And also understand that older adults can benefit from routine screening and treatment for co-occurring mental health disorders. Next slide, and thank you. Any questions?
Did you want to have questions after each segment then?
I think so. I think, yeah,
Okay.
When I made this slide, I had this here, but if people could write down the questions, then we can get through it after Joe and Mary present.
Oh, okay. We'll wait till the end then. But everyone, I'll keep track of your questions, so don't worry.
Mm-hmm. Thank you.
Hi, everyone. Thanks for having us here. I'm going to be talking about unhealthy alcohol use in older adults, and we'll talk about screening and having conversations about alcohol use, a little bit of diagnosis, although Adel went over that really well. I'll talk a little about a brief intervention you can do as in primary care for at-risk drinkers who, especially those who don't have an alcohol use disorder, but might have risky drinking. And then we'll talk some about options for making changes in drinking and pharmacotherapy, which is very underused. Next slide. So alcohol is the most common substance use issue in older adults. About half of adults over 65 do drink, and 14.5% of those who drink have unhealthy use, and we'll talk about how you define that. And that a lot more of them, more than half of drinkers, have some kind of hazardous or harmful drinking, meaning that they have some kind of medical condition. It could be depression or mobility problems that where drinking makes it more risky. We know that alcohol metabolism is less efficient in older adults, and so smaller amounts can be problematic. Withdrawal can last longer. And we also know that binge drinking and treatment admissions in older adults have been increasing. Underdiagnosis is a theme here, right? That people can present with medical or mental health issues, or maybe as medications that aren't using. I think of depression as a really common one. You start an antidepressant, it doesn't work. Maybe that's because of alcohol, very common thing. Next slide. So this is the pyramid of alcohol use. At the lower end there, most people either don't drink or have low risk use. And then what we're looking for when we're screening patients is unhealthy use, which is that orange triangle. It includes people who have use disorder or more severe problems, but also people who have problems related to their drinking or simply risky use because of other medical issues that are going on. So when we're screening, we're really looking for that pyramid of unhealthy use. Next slide. So the United States Preventive Services Task Force does recommend primary care alcohol screening. And it's primarily because if you screen people and intervene on folks mostly who have the riskier problem related to alcohol, minor problems related to alcohol, that your counseling in primary care can change things. So that's why the Preventive Services Task Force recommends screening in all primary care settings. So how do you do that? Do you sometimes drink alcoholic beverages? If they say no, then I find that it's helpful to figure out if that's for a reason, that they had a problem in the past. So have you ever had a problem with alcohol, or what made you decide not to drink? Could be good questions. Maybe they have a family history and you might want to know that. If they do drink alcohol, then there's a single question that you can use. How many times in the last year have you had 5 or more drinks in a day? That's for men under 65. Actually, the question for older adults and for women is 4 or more drinks in a day. And that question is pretty good in terms of sensitivity and specificity for finding that unhealthy use. Again, that's people with a use disorder and also people with unhealthy use that doesn't meet criteria for a use disorder. And then if any of that is, if they say anything but never to that question, then it's really worth going into how much they drink on a daily or weekly basis, as there are healthier or safer drinking limits that are listed on the right there. 3 drinks per day for older folks and women, and 7 drinks per day or drinks per week if they're younger and man. And for older folks, they may drink at home, they may buy alcohol in a big bottle and keep it around for a long time, and they may not be able to tell you exactly how much alcohol they put in a drink. They may say, I have 1 drink, but you don't really know how much alcohol is unless you try and figure it out. So do you buy, what do you drink? How much do you buy? And then figure out how long it lasts. Sometimes you need some math to figure this out. There are some alcohol screening tests for older adults, but they're quite a bit longer. And this outline that I've given is really how everyone's recommending you screen in primary care. Next slide. So if folks do screen positive and you've assessed how much they drink, you want to figure out if they have a use disorder. And Adel's gone over that really well. I have a conversation about unhealthy use. Tell me more about your alcohol use, or where does alcohol fit into your life? Those really get people talking in a way, and I can demonstrate that I'm not going to judge them, and I'm going to be on their side about it and try and reflect whatever they say about that so that they talk more. What are some of the good things about alcohol? Can be a useful way to have a conversation that might be less threatening to patients. And then after they've told you the good things, you might ask, what are the less good things? So you can kind of get a balance there. If they've had prior treatment, that's important to identify. And the other thing I think is really important, especially for older adults, is why are they drinking? What do they see as the reasons? Are they coping with isolation? Do they have pain? Are there mental health issues going on? And so those are kind of the things I'm thinking about as I have a conversation, but really I want to be curious. I want to be non-judgmental, and I want to get people talking more, me talking less. You want to have this supportive conversation at the same time that you identify people who have problems, especially a use disorder that might need a more intensive treatment or medication. Next slide. So I'm not going to go through these. Adel did a great job going through them. I'll just identify that these are the symptoms that we're looking for. And if you head to 4 or 5 or more of these, that's a moderate to severe use disorder. And those are the people that we know medications work for. So we'll talk a little bit more about medication later. Next slide. So in older adults, this idea of drinking to cope with a mental health issue is really a prominent one. And it's easy to miss alcohol problems because people present with depression or present with anxiety or poor sleep or nightmares, or maybe they present with cognitive decline. And you might be trying to figure out those other diagnoses. And it's easy to miss the alcohol in there because the patient may not realize the connection. Drinking also interacts with other medical issues. So people with pain or hypertension or sleep problems, it might be hard to treat those if they're drinking. And mobility, of course, is the risks of mobility go up with alcohol. So falls might be common. So you might present with a medical issue, turns out to be an alcohol use disorder underlying that. Drinking to cope with isolation. This is, again, listening for changes in support or environment or activities or livelihood that Adel went over as some of those risk factors for a use disorder. And then polypharmacy, really important. We go over that so much in older adults, especially CNS medications, those that affect the brain, and alcohol really are going to have more profound effects with alcohol use and more negative effects. Of course, folks may have a lot of hesitancy to seek treatment for an alcohol use disorder, and stigma is a big part of that. For drinking is supposed to be fun. You're supposed to be able to manage your alcohol on your own, and when people have problems, they may not want to bring that to our attention. And so all of these medical, mental health, and social issues really are important as part of the treatment for people's alcohol use. If they're drinking for a reason, it's important to address that. Next slide. So once you've had this conversation, a brief intervention for at-risk drinkers has been shown to be effective for those people who don't have an alcohol use disorder, but do have some at-risk features. So one way to do this is to summarize. You've had a conversation. On the one hand, these are the pros that you've identified, the good things about alcohol. On the other hand, here's the problems that you've identified with the drinking. What do you think? What do you think about that? What do you think you might want to do? Often what we do as medical providers is try and do a lot of education. And we want patients to know that their hypertension's out of control because they're drinking, or their depression medicine isn't going to work because of their drinking. But we have to be careful about educating patients. We really want to know what they already know, so we're not just going to prompt a lot of resistance. So what do you know about the health effects of alcohol? Get them to talk about that. They may not know some of the things that are important, but if you are going to give education, you always want to ask for permission. Can I let you know some of the other effects? And then assuming they agree and want to hear about that, you can tell them. And then what do you think about that? This is a motivational interviewing ask, tell, ask is the jargon that they use in motivational interviewing. But I think everyone can benefit from this in their interactions with patients. So you're always asking permission if you're going to educate or you're going to advise. Can I give you some advice about your alcohol? I'm concerned about your drinking because of the effects it's having on your blood pressure or on your reflux disease or on your mental health. And then just giving some advice, can quitting or cutting down would be safer. And always assessing for readiness. What would you like to do about your drinking? What are you ready to make a change? Do you want to cut down? Do you want to stop? Do you want to make no changes now? Those are the choices. Next slide. So folks may have good reasons to choose one or the other of these. Some of which choice is best for a person. Some reasons people might decide to cut down. They might not really have that many problems. They might have been able to drink less in the past and see the problems they are having as something they could address. Maybe they like drinking but want to lose a little weight, so they might want to cut down, or they might want to cut down and see cut down and set a limit might work to improve their mental health or improve their medical status or improve just how well they feel. Some people might decide to stop drinking altogether because of the health risk, because they can't control it when they start, because cutting back was really hard for them. Or maybe it's a social reason that they found other people who aren't drinking that they want to hang out with. Family history is another reason. Some people cite for wanting to stop because they know they saw family members really have a lot of trouble. And then some people might decide not to change at all. Maybe they need to change their social situation. Their partner might need to buy in, or maybe they want to track their drinking instead and see if they can get a handle on it themselves. Maybe they want to get help with another problem first and see if the drinking goes away by itself. So all valid reasons that you can be trying to help patients make that decision. Next slide. So here's a menu for things that people might do for their alcohol use disorder or for unhealthy alcohol use. They might want to handle it on their own, setting a drinking goal, measuring their drinks, maybe alternating drinks, maybe eating before they drink, so it might reduce the effects of alcohol. There are lots of tools that people can use, and I've given a website that has a lot of ideas there. Some people might want to do some kind of counseling, and it doesn't necessarily need to be alcohol related counseling. It could be that they have a problem with depression and they want to do counseling related to that and see how that affects their drinking. Sometimes people do drink to cope with mental health problems, and they may get help with those mental health problems, and the counselor may identify the alcohol as well and work with them on both. Some of the counseling techniques that we know work for alcohol use are motivational interviewing. CBT is cognitive behavioral therapy. CRA is community reinforcement approach. These are things some therapists might be expert in or know how to use, but may not be their primary focus. There are group-based alcohol treatments or rehab, which are specialized addiction treatment programs. These can be outpatient. IOP is called intensive outpatient. That's more like multiple times a week. Outpatient might be weekly. Residential is residential. You might be in treatment for a month or even longer. So those are more intensive and usually reserved for folks who have trouble, who don't do so well in less intensive programs. Peer support programs, you've all heard of AA and Smart Recovery is another version of that, which doesn't have so much talk about the higher power. So there's lots of ways that people can find peer support as well. And then medications, which we'll go over a little bit as well. Next slide. So what we know from research, most people do get better but they do take different paths. So it's not one thing treating everyone. No one treatment is best for everyone. People do not have to hit rock bottom. That's a misconception. People can change even when they have minor problems or even before they have problems if they understand the risks of drinking. Counseling just by itself helps 2 out of 3 people. We generally recommend that outpatient programs be the first line if they do want some kind of specialty treatment. It works as well or better than inpatient programs for most people because it's taking people in their current context, in their community. And if you go inpatient, you're going to have to return to that milieu or your environment after inpatient treatment. So you might as well give it a try with outpatient program first. AA does help people who want to stop drinking. There are other support programs, but they're not as well studied. And then stopping drinking, of course, is the surest way to prevent problems. Next slide. So pharmacotherapy for alcohol use disorder, we want to offer that to folks with moderate to severe use disorder, and have to understand in this context what the goal is. The goal may be abstinence for some people, but you might be able to make a big positive effect, not only by helping people stop altogether, but by helping people reduce how much they drink, and actually how many heavy drinking days that people have. So for folks who are over 65, that's 4 or more drinks in a day. How many drinking days people have is the most closely associated with the consequences of alcohol use. So it's actually a measure that all the clinical trials use, and it's probably the best measure for the effects of a medicine. Experts generally recommend that you treat people if you're going to use a medication for at least 6 months, but often longer. And before treating people with for a use disorder with a medication, you want to assess their risk of withdrawal. Do they need actually a medical detox? And that's pretty easy. You can just say, have you had complications? Have you needed inpatient support in the past for your withdrawal? And if they have, they will need it again. There is another scale there, the prediction of alcohol withdrawal severity scale. You can use that, but really it's mostly have they had problems before that needed medical attention. Next slide. You skipped one. Yeah, there you go. That's the one. There we are. So I'm just going to go over a few of the medications. These are FDA approved for alcohol use disorder, and naltrexone, which is an opioid blocker, is generally first line for people with alcohol use disorder, unless they're taking opioids. It's an opioid blocker, so you can't be giving them to people who are taking opioids regularly. It is safe for people who are actively drinking, and really what it's shown to do is moderate how much people drink when they drink. Again, those heavy drinking days go down. It is safe in folks who have hepatitis, even up to 5 times the upper limit of normal. We don't have data for folks who have such severe cirrhosis that they have encephalopathy or ascites or bad bleeding. But we do know that it's safe in people with liver disease, so that shouldn't stop you. It has an oral form and it has a monthly IM intramuscular form called Vivitrol. And it's pretty easy to tolerate. Nausea, maybe some headache. Usually that improves after you've been on it for a little bit. And the Vivitrol, the IM, seems to have a little less side effects. You can also lower the dose. Usual dose for the oral is 50 milligrams, but you can lower it and just see if they can tolerate it. And you can get injection site reactions with the intramuscular version. Next slide. Camprosate or Camprol is another FDA-approved medication. Usually it's second line because it's 3 times a day, and many people have trouble with that. It's probably as effective as naltrexone. Affects different receptors in the brain that impact withdrawal and reward. You can see the weird dosing that it has. And really, it's mostly been shown to help people who are abstinent stay abstinent. It's safe in liver disease because it's not metabolized at all through the liver. But if they have kidney problems, then you do have to adjust the dose. Side effects are pretty minimal, a little bit of GI stuff, but usually people can get used to it or start with a lower dose and go up. Next slide. And then Disulfiram is FDA approved. It's not usually recommended unless you can get somebody to actually help with supervision. And so if people take it, it works, but it's very easy to stop and then drink. It causes buildup of a toxic alcohol metabolite. So really have to be abstinent to start it. And that's really what it's supposed to do, is make people sick if they drink. But again, they can stop it and then drink. So it's dosed daily, pretty mild side effects. Next slide. And then there's some non-FDA approved medications that have data showing its effect on alcohol. Gabapentin is one, and really has been shown in folks who've gone through withdrawal that it increases abstinence and decreases drinking with 12 weeks, 4 months of treatment. And that's benefits sustained even after they stop the medicine. That's really the setting you want to think about it, early recovery, because people do have lots of symptoms when they've gone through withdrawal and have trouble with sleep and anxiety and craving. That's really when you want to think about gabapentin. Some trials have not shown benefit, the long-acting gabapentin, and in other trials have shown that folks with more withdrawal severity, but not less withdrawal severity, seem to benefit more from gabapentin. It works with naltrexone. So you want to think about it in folks who've had alcohol withdrawal, or if they've had another reason to be on gabapentin that's pretty commonly used. Topiramate has effectiveness for alcohol use disorders, but it does sedate many people, can cause cognitive impairment. So unless they have another reason for it, I don't generally give them that. And prazosin's the other one to keep in mind. It's effective for PTSD, especially folks who have nightmares or flashbacks. And it's shown to be effective for alcohol use disorder in folks who don't have PTSD. That was just one trial, so it may be early to recommend it, but you could consider it certainly for people who do have PTSD. Next slide. So just take a look at what happens when people get a medicine. This is an example, and I'm just going to focus on the part of the graph here that says overall. The leftmost bar is pre-treatment, how many heavy drinking days in the last month people had, which looks like around 20 on average. And if people come into treatment, get some counseling and a medicine, even if it's placebo, you can see that next column, it goes way down. And then the other two are naltrexone at the 2 different doses, and that is a dose response effect of the medicine. But you can also see that when people come into treatment, get some counseling and a medication, it really helps. Next slide. So pharmacotherapy is really underutilized. It's prescribed for less than 9% of Americans with the moderate to severe alcohol use disorder. If you don't get a medicine, relapse rates are very high, about 80% within a year after some kind of non-pharmacologic treatment. The effect size for pharmacotherapy for alcohol use disorder is about what it is for antidepressants. So if you treat depression, you can treat alcohol use disorder. And just like antidepressant treatment, it's better with counseling. The placebo effect, or maybe it's just the talk therapy, the therapy that goes along with medication that has a strong effect as well. Next slide. So I don't have time for all this. This is, I hear this from, and I am a primary care doc, so I get it that there's a lot to do. Busy clinicians worry they don't have time to provide SUT assessment and treatment. And I just want to give a little advice for how to make it work in primary care. One is just don't do it all in one day. These conversations can happen over time. I really encourage people to have a problem list, which includes drinking on it. Where did the conversation end? Maybe you don't even get to it. Maybe maybe you didn't do it at all one visit because they had other issues going on. But if you can track that and even note when you didn't revisit it, to remind yourself just to check in. Reducing our focus on education and telling people why they should stop drinking, really try and reduce that. It takes a lot of time and it's not effective. So focus again on the why. Why do people drink? Why do people want to change? What are they thinking? Get them talking rather than you. It takes a lot less time. And then if people do want to make a change, you might consider making an extra appointment to go over options and really focus on that, because it takes time for people to understand their options and make a decision. Next slide. So this is just screen for unhealthy use. Use that single question. If it's positive, you want to see if they have a use disorder, have a conversation about the patient's concerns and goals. Do a brief intervention for those with unhealthy alcohol use, and prescribe medicine if they have moderate to severe alcohol use disorder. And I'll stop there and hand it over to Mary.
Great. Okay. Thank you so much, everyone, for your time this afternoon. We're going into the home stretch. So for the final section, we'll move into talking about opioids. Learning goals here are to, one, review screening and diagnosing opioid use disorder. So very similar to what we've been talking about, but with just a few important distinctions. Review medications for opioid use disorder, specific things to consider in older patients who may be taking them, and then talking about some of the nuances of taking care of older patients who are prescribed opioids for chronic pain, who may or may not also have opioid use disorder, and spend a little bit of time kind of exploring that overlap, which can be really tricky sort of as people working with those patients. Next slide. Rates of opioid use disorder among older adults have risen significantly. A lot of this is probably due to the dramatic increase in prescription opioids that would have happened, between the mid-90s and the late 2000s. I saw one number that the rate of opioids prescribed for older adults during office visits in that time, like 1995 to 2010, increased by a factor of 9. So there was a really dramatic rise during that time. And as a result, more older adults are experiencing and seeking treatment for opioid use disorder. And if you think of kind of all the downsides that we now think of with chronic opioid therapy, things like cognitive impairment, medication interactions, overdose, sleep problems, those can all be really amplified for older patients. Next slide. The evidence on universal screening for opioid use disorder is actually a lot more mixed than it is for something like alcohol or tobacco, where, like Joe said, there's good evidence to say that it's helpful to screen everyone, and there's sort of a clearer protocol to do that. The USPSTF recommends screening all adults for substance use sort of in general, but it's a grade B recommendation and comes with the condition that we should really only be asking patients if we have the ability to connect them to appropriate care. So there's no direct evidence that universal screening is beneficial, and it's been shown that a brief intervention that is really effective for alcohol, for example, is unlikely to be helpful for other substances. At the same time, you're sort of thinking practically, it can be helpful information to know for sure, sort of as we're taking care of patients. So the evidence isn't super strong that we should be asking everyone about it, but at the same time, it's a reasonable practice, especially if you have options for treatment. Next slide. And then the criteria for opioid use disorder are the same as for other substance use disorders, so we won't spend a lot of time here. The major nuance is just that any patient who's taking opioids on an ongoing basis will develop tolerance and withdrawal, just the sort of nature of how they affect the body. And so if these happen as a result of taking an opioid as prescribed, we wouldn't think of that as sort of being criteria for an opioid use disorder. Next slide. Okay, so we'll move now to talking about treatment options. Similar to alcohol use disorder, a minority of patients with OUD are prescribed medication, but they're incredibly effective. So methadone and buprenorphine naloxone or Suboxone are really the mainstays. And then extended release naltrexone or Vivitrol is also an option. They all work sort of in general the same way by preventing opioid withdrawal and cravings and reducing the risk of overdose. And then we'll just touch briefly on naloxone. It's not a treatment for opioid use disorder, but super important since it can rapidly reverse an overdose. Next slide. So I wanted to put this graph in really just to sort of leave you with a visual for the fact that medications for opioid use disorder save lives in a really sort of dramatic way. So this is Baltimore between 1995 and 2009. And you'll notice that the blue line is methadone patients. The green line on the bottom is buprenorphine patients. And so as both of those numbers go up, the number of deaths, so heroin overdoses, which is tracked by the red line, goes down sort of precipitously. Next slide. Okay, so I want to just talk a little bit about some of the differences between methadone and buprenorphine and how that might kind of affect older patients who are on them. So one of the biggest practical differences is just prescribing. Methadone can only be prescribed for opioid use disorder in highly regulated, federally certified clinics, but buprenorphine, in contrast, can be prescribed in general practice. And it's much easier than it used to be for prescribers to get the DEA waiver that's needed to prescribe. So the patient experience can be very different between methadone and Suboxone because of the different settings where they're prescribed. But when you compare them head to head, they do have a similar decrease in cravings and similar remission of substance use. There are a few kind of important risks and benefits to know for each of them in thinking about how to individualize the choice. So a really important quality of buprenorphine is that it has a lower risk of overdose compared to methadone and compared to other opioids. We'll talk about that a little bit more in the next slide. And then methadone has some considerations, especially in older adults. It does have more serious medication interactions, and it's more likely to lead to a prolonged QT interval, so increasing the risk of a fatal heart arrhythmia. And that's especially true in older adults who might have other medications or other heart conditions that already increase their risk. So definitely something that can be a limiting factor. But if you're thinking about retention in treatment specifically, then methadone generally seems to be more beneficial than buprenorphine for that. So at the end of the day, they're both really effective medications, and the best medicine for any given patient often depends on availability and which medication is more acceptable to the patient. And so just to sort of quickly go into why buprenorphine has such a good safety profile, because that's definitely one of the really important features of it. Just to think a little bit about sort of why that is. So buprenorphine is what's called a partial agonist. This is probably an oversimplification, but this is the only way I found that like helps me think about it. I think of it as meaning that when it binds to the opioid receptor, it only activates it partway. So it doesn't turn it all the way on, it turns it partway on. In contrast, other opioids like methadone or heroin that are full agonists turn the receptor on all the way. So sort of all of the like cascading hormones that come out of that activity is sort of turned on as much as it can be. So what that means sort of in practically for the patient is that there's a ceiling effect to buprenorphine. So you could take more and more and more, but the receptor can't generate any more activity with those higher doses. And so things like respiratory depression, sedation the risk of those is much lower because even if you're taking much, much more than is prescribed, for example, you're not going to necessarily run into those side effects. So overdoses are very rare and usually happen in the setting of other sedating medications or other CNS depressants like alcohol. Next slide. And then just to quickly talk about Vivitrol and Naloxone. Vivitrol is also, which is effective for alcohol use disorder, also effective for opioid use disorder. In both cases, it works by blocking the opioid reward circuit. Like Joe mentioned, it's really challenging for patients to start naltrexone because you have to be fully detoxed from other opioids. And that means often a few days, a week, a couple of weeks of feeling pretty bad during withdrawal. So it's harder to start compared to methadone or buprenorphine, but it is effective once people are on it. And then finally, Narcan is super, super important medication, not a treatment for opioid use disorder, but can rapidly reverse overdoses. And the most important thing to know is probably just that it's safe and effective in older adults. So really anyone who's prescribed opioids or is taking non-prescribed opioids should have it available at home. And ideally, there's going to be someone who could administer it to them, since it's not something that you can do for yourself necessarily. Next slide. Okay, so in the last section, we'll transition into talking specifically about patients who are already on high dose prescribed opioids. So the pendulum has swung really far away from sort of when we were prescribing lots and lots of opioids in outpatient settings. But for patients who were already on those opioids, sort of when it was common practice, and when they were started before we learned that they aren't necessarily great medications for chronic pain, before we sort of fully understood the risks of medication misuse and overdose, it puts them and the doctors and providers and nurses taking care of them in a really hard position sometimes. So chronic pain and addiction have a lot of similarities, and clinically there's a lot of overlap. Understanding whether or not someone has both chronic pain and a use disorder is important, but it can be really challenging. One of the things that makes it most challenging is probably stigma. So sometimes that might be from the medical community, often just from sort of general society. So if that's something that's coming up in a conversation with a patient, one strategy is just to start with their experience. So really it's sort of acknowledging and understanding the suffering or pain that people might be experiencing. And whether that's related to pain or related to substance use or both, it puts you on the same side. Sort of lets them know that you really care about them sort of first and foremost as a person. And then it can also be helpful to normalize it. So any patient in the world who's prescribed chronic opioids has a higher risk of a use disorder, just sort of the nature of the medication. So it can be really important to emphasize that you're not going to abandon them. This is something that lots and lots of people are navigating. And you're sort of thinking about safety and you're coming from a place of concern, but not with judgment, and most likely not with a plan to sort of abruptly stop therapy. And so sort of setting those, any sort of worries or anxiety around that to rest can be really helpful. So these are just some questions that might help you start a conversation about it if you're sort of figuring out how to open the door with a patient. And again, this is about sort of trying to suss out, are they experiencing symptoms of a use disorder, which is sort of separate from their underlying chronic pain. So sometimes you can ask quite directly, like if it's something that they're concerned about or if someone else is concerned about it, you can ask if the pain is so bad that they need to take extra medication and then run out later. You can ask if they've experienced any kind of negative effects that's made them want to be able to cut back, like if they're sort of recognizing, oh, this is doing something in my life that I don't like. And then you can ask if it's taking up sort of more mental space and energy than they wish it did. Ultimately, your goal is to try to understand if what they're experiencing, again, is a manifestation of chronic pain or if it's consistent with a use disorder as well. Next slide. Okay. So if a patient with chronic pain who is on prescribed high-dose opioids and they meet criteria for an opioid use disorder. So this is a situation where you're like, you know what, like I feel confident that they meet all of those criteria. Then it's really recommended that they do switch over to a medication for opioid use disorder, meaning usually methadone or Suboxone. There are a few reasons for this. Long-term methadone and buprenorphine are both safer. That's why we use them sort of rather than other opioids in part. And patients often do well with the transition. And then it can open up some other doors. So oftentimes patients will feel better because they might be experiencing less side effects. And it can make room for patients to work with other therapy modalities, sort of as those other things are stabilized. Next slide. So if patients are on chronic opioids and they do not necessarily have signs of an opioid use disorder, then it's a little bit of a more nuanced conversation in terms of whether you continue the medication as is, consider a slow taper, consider switching to another opioid like Suboxone. Safety is definitely a big consideration. So across the board, a partial agonist like Suboxone or a lower dose of another opioid is always going to be safer than a high dose. Like a high dose full agonist will always be more dangerous than buprenorphine or a lower dose. But you'll also be thinking about that particular patient, any additional safety concerns you might have, and whether they've actually had any like functional improvement and benefit from the chronic opioids that they're prescribed. So since buprenorphine is the medication that's sort of easy to prescribe in general practice, we wanted to give you some scenarios for patients that you could meet in a sort of general geriatrics population, and give some guidance on whether or not you would consider switching to Suboxone. So first, if a patient overdoses, or if you're concerned at all about unsafe use, then switching to Suboxone is definitely the right choice because of that safety profile. And that's a pretty urgent thing to do. Like, you should really try to make that switch as soon as possible, if you have any concern about safety, or if they've recently experienced an overdose. For a patient who has opioid use disorder and chronic pain, and they have not gotten improvement from the high dose chronic opioids, then it's probably going to be helpful to switch them over to buprenorphine. Again, it's because it's safer and it's the better treatment for opioid use disorder. The urgency might be slightly less than someone who's just overdosed, but talking to them about it should still be a priority. And then a more gray area is patients who are on chronic opioids but do not have opioid use disorder. So if they're a patient who's on a very high dose, then buprenorphine is probably a safer alternative, although we don't necessarily have sort of head-to-head studies in that population. It's important to know that only a couple of buprenorphine products are currently FDA approved for pain, the transdermal and then one of the IM formulations. So using other forms like the sublingual or tablets is technically off-label, and sometimes can cause insurance coverage issues for some patients. And then for patients who are on low-dose opioids and are getting functional improvement from that, there's probably not going to be much additional benefit to be gained from switching to Suboxone. You're not going to necessarily gain a lot more in terms of sort of safety benefit. And these are patients who it might be possible to do a taper kind of over time. That's something that sort of would come with lots of discussion and maybe trying other therapeutic modalities and things like that. Next slide. And then finally, just want to acknowledge that opioid therapy is just a very small piece of the puzzle for managing chronic pain. So while we're focusing here on opioid management, treating underlying anxiety and depression, recognizing and treating central pain syndromes like fibromyalgia, and then utilizing all of the non-pharmacologic treatments that are out there are definitely cornerstones of treatment. And ideally, this is all kind of happening at the same time, although sometimes especially if people are dealing with really severe opioid use disorder, helping people stabilize on medication can be a really, really important first step that sort of opens the door to address all of these other potential factors. Next slide. So take-home points from this section. Opioid epidemic has impacted all demographic groups, and that includes older adults. Opioid use disorder treatment with buprenorphine or methadone is highly effective. It saves lives. Conversations to diagnose opioid use disorder are important, and it can be really tricky, especially in patients with chronic pain, to really sort of tease out whether or not there's a use disorder that's happening at the same time. It's great to learn to treat opioid use disorder with buprenorphine. It can be done by the general practitioner in a general outpatient setting. It's a great medication. And then don't forget to treat chronic pain effectively with all of the different modalities that we have. So that's the conclusion of our talk. I think the big picture take-home points are really the same. Substance use disorders are generally underdiagnosed, especially in older patients, and there are effective medications, especially for alcohol use and opioid use disorders, but they're generally underprescribed. So having it on your radar, talking to your patients about it, screening when it's appropriate, and then feeling empowered to prescribe medications and recommend other kinds of treatment or therapy that can help really sort of go a long way towards helping folks with something that's often not recognized. And that's it. So thank you all for your time, and we'd love to hear whatever questions or comments you might have.
Oh, this is just great. Thank you so much. What a really nice sort of broad as well as deep discussion about substance use disorder. I've got some questions here that I'll start off with, and then I'll probably trigger some others. How do cravings exhibit in older adults? This could be any one of you.
I guess Joe, Dr. Merrill can also chip in, but the craving, I mean, it's like I mentioned, it may be similar to general adult population, but I guess some patients sometimes have the mild withdrawal symptoms that might lead them to want to use. But they might describe it as, they have this obsessive or compulsive desire to want to use because they're just not feeling comfortable without it. It's because of the chemistry, brain chemistry changes. If they're not using it for some time, or if they're in an environment that triggers them, they have that craving. I mean, I've heard it in different ways that people say it, but it's basically feeling like the urge to want to use, and it's basically they know that they have that feeling, that uncomfortableness that they need to use now. And I guess I'm not really explaining it so well. Joe, do you have any tips? I mean,
Yeah, well, I think it's interesting because it's actually it's a new criteria for substance use disorder in the DSM-5. So it is, how do you ask about craving? I think about it as like, do you think about use a lot during the day? And this is a good one for pain medication, I think, as a way of sorting out opioid use disorder. And do you think a lot about your pain medication during the day? Is it hard to stop thinking about your pain medication, or is it hard to stop thinking about drinking until you have a drink? Something like that. It's there in your mind a lot. It's very salient in your life.
Thanks much. We also had a couple of people asking about the SAGE questionnaire, and I think Dr. Mazanderani had provided information. I put it in the Q&A, but I'm going to put it in the chat. Also, the information that was sent about that questionnaire. Just a minute here.
Yeah, it's pretty easy one to use and self-administered. You can use that. And also, so going back to craving, sometimes I ask, like, how long do you go before you feel the need to use? Or like for smokers, especially in the morning, I would ask, how long after you wake up do you feel like you need to use or smoke for tobacco use disorder? But for alcohol, it's like, how many hours do you go before you have to drink again? Yeah, so it is a subtle one, but you can ask them that way and get an understanding.
That's helpful. Thank you so much. I think Lisa had also put into the Q&A about the slums being a common cognition screening tool. Is that one that you've used before?
I know about it, but honestly, I haven't used it much.
Okay.
Yeah.
All right. And Wendy is wondering, do any of the medications that have been mentioned to help with addiction disorders, do they help with sugar addiction or binge eating at all? I thought that was interesting.
Yeah.
I don't think we have data about that. Yeah.
I think the topiramate
and naltrexone, I guess, has something going on.
Yeah. So I know a little bit because I did some obesity medicine before. So yeah, if you combine some of these medications with other medications, there is some evidence that those medications really didn't do well. They're costly and they have many side effects. But topiramate is combined with phentermine low dose, and they dose them in a way so that they can sell it as a brand name. So it's not the phentermine regular dose, it's much lower dose, like 4.5 milligrams, 6. Anyways, there is some benefit because some patients have lost some weight, like topiramate has been tested as well. One of the side effects is they may have some nausea, they may not eat as much. So yeah, when you combine it, there is some evidence, but they're very poorly, they work really poorly. Patients gain the weight back right away soon after. Naltrexone also combined with bupropion, that's another brand name for that, but that's also used as well, but they're not, unfortunately, very effective long-term. The best one is another one.
Riva is asking about how you account for the difference in the effectiveness of medications in men and women.
Yeah, so I think that might be referring to the slide I had up about the naltrexone study that had the overall and then men and women broken out. Actually, I should have been more clear to ignore the men and women difference. Very few women in that study, and also that hasn't been replicated in other studies. So I would, my point was that getting people to take a medicine or even a placebo seems to have a big effect on people's drinking. Just coming into some form of care for alcohol use disorder is very important. And that's in contrast to opioid use disorder, where if you come into treatment, you can, and you don't get a medicine, you're gonna do very poorly. Almost no one will succeed without medicine. Whereas with alcohol, the medicine isn't as essential to the treatment.
And Caroline is wondering, how do you handle patients with at-risk legal substance use disorder or other kinds of like alcohol disorders when they take offense and feel you are asking about areas in their life that are private and under their own discretion? Do you have any responses that you offer to that?
I think I was doing a thing for medical students on taking a history. And it was the first time that I learned that like there has been some research into sort of like what kinds of communication strategies like help patients feel more comfortable and sort of give like more like reliable answers to sort of say like if they're like, you know, drinking X amount, that it is that amount versus sort of feeling compelled to minimize it. And so I feel like those strategies like feel like they come in handy in that kind of a situation, which can be really hard. And so one of them is transparency, sort of saying like, you know, this is why I'm asking about it. It's because, you know, this is something that I'm concerned about, or I'm worried about, you know, safety or something like that, that sort of orients you around that. But then also making sure that you're clear that the ball is in their court. Like you're asking a question and they absolutely have the right to say like, that's not something I want to talk about. And so just reminding them that there's no coercion, there's no, because there is sort of a power dynamic that's inherent in just sort of like healthcare and being a patient. And so I find that sometimes it's helpful just to be like, we can talk about this if you want to, we don't have to talk about it, we can come back to it, just sort of giving a lot of different options and giving patients sort of the autonomy to choose like which of those roads are you going to take.
And how are you adjusting your approach for sort of societal changes in alcohol consumption related to the pandemic? More forgiving, more concerned?
Yeah, I mean, so societal changes to alcohol?
Well,
use?
I've been seeing some articles about this also, that alcohol consumption seems to be shifting a bit, more alcohol consumption, somewhat attributed to just being locked down with the pandemic. And so what are your recommendations for that?
Yes, yeah. I remember seeing that, something similar. And I mean, that just heightens my awareness and wanting to ask about it and see how patients are coping with their issues that are coming up and anxiety and such, and sleep. I mean, it's unfortunate that happened, and I know in some countries they try to ban that, you know, curfew on that, but it is. I mean, I bring it up if I know that pandemic has, you know, affected somebody with their work or they're not working such. I make sure to ask about it. It just heightens my awareness. That's all I tend to do. But I unfortunately can't change, you know, political issues and that sort of thing.
I think that if you, the question sort of implies that you could be sterner or less stern with patients depending on something. And I think trying to keep it more on the level of, you know, what's safe, how does it interact with your medical issues, what is, you know, your concern is for their health. And it's totally understandable why the pandemic has led to people drinking more and coping with isolation, coping with loss of livelihood. Those kinds of things are clearly happening, and you want to be non-judgmental and understanding that it may be normal to drink more when under stress, but what are the consequences of that for you?
So Chrissy is wondering if there's a reason buprenorphine isn't used more for chronic pain rather than the more traditional opioids.
I think a lot of it is just, I think that will probably be changing over time. I think a lot of it is just sort of the amount of time it takes for your practice to really change. I think especially I think the X waiver definitely, and just sort of the like required number of hours that people had, even if you didn't actually need the X waiver to prescribe it for pain, I think like that sort of subtlety and then the sort of added barrier of doing it. And I think it was both like a logistical barrier and sort of like an extra thing that people had to do. And I think it definitely like enhances the idea of like, this is a medication that like maybe we like shouldn't be prescribing or shouldn't be available to the generalist or things like that. Like, I think that just sort of like feeling uncomfortable with it was enhanced a little bit with the sort of required training, which we really don't have for any other medication. And so I do anticipate that would change. I'm curious, yeah, if Joe and Adel, you have other thoughts on that.
Yeah, I think so. Talking about buprenorphine in general, unfortunately, the patch or Belbuca that are approved for pain management, usually they weren't covered by insurance, or they're you have to go through hoops to try to get it covered for chronic pain, even just to get them covered. And then Suboxone, that's approved for opioid use disorder initially in U.S. There's some stigma associated with that, unfortunately. When some patients, when I try to initiate that treatment for them, they have this whole idea about trying to treat substance use disorder. So it's really hard to, have the conversation sometimes with them when they come from that mindset of Suboxone just being for opioid use disorder. So with that stigma and just trying to, educate them a little bit more or ask what their concerns are, I've got to, start Suboxone on patients because it's covered and use that for chronic pain. So I just feel that stigma is still an issue, and also with insurance not covering things like Belbuca. It is a lower dose, so for patients on higher doses of opioids, it may not help so much. You have to use Suboxone, that's a higher dose of the buprenorphine, and those are the main barriers. And there are some patients who truly don't do well on buprenorphine, depending on their pain and such. So you have to just keep that in mind for some patients. It's not always, it's great medication, it's much safer, but it's really hard sometimes to transition patients on higher doses.
That sort of relates to a question that Nick was asking. So I'll just ask it, and maybe you can talk a little bit more about methadone. How common is it to have older adults using Suboxone or methadone treatment for long-term chronic pain management? How common is that?
Joe has more experience, but I'll let him talk about it. Yeah, I don't think it's that common there's a couple of ways to think about that. Are there older folks who are on methadone? And the answer to that is certainly yes. If you look at people in methadone treatment programs where they're being treated for addiction, that population has been, there's definitely an aging cohort of people who have been on it for many years, even decades, and done well with it. So there's that aspect. For chronic pain, really methadone's probably the least helpful medicine because it's really less safe than even other opioids. So you wouldn't want people on it for chronic pain. Suboxone is so much safer. I think there's a lot of room for improvement in our practice to get people who have had chronic pain problems, are aging on opioids that are getting increasingly risky for them for the reasons we've outlined. They're more likely to fall. There's more cognitive issues with it. Those are the people I think that we really should be considering for buprenorphine treatment. And whether that's for a use disorder or for a chronic pain treatment, I think we'll see more of that in the future.
And back to the idea of pharmacotherapy for use disorders, do you have any other thoughts, additional thoughts about the reason that pharmacotherapy is underutilized?
Well, I think a lot of it is stigma. I have to say, and it's stigma within the medical community that people don't see themselves as that substance use disorder is part of their practice. They see it as something, and that's a historical thing that substance use disorder treatment has been separated from medical care in many ways. A lot of the residential programs or outpatient programs might not have much in the way of medical connections. That's changing slowly, but it's still an issue that doctors in their training historically haven't had the training to do it, and that's changing. And both Adel and Merrill have been through a fellowship in addiction medicine. Those are new, but I think you'll see more and more folks taking this on, and it is really something that can happen in primary care. And I'm sure there'll be better education in the future.
So a question about residential medical detox for older adults. What would trigger that recommendation for an older adult residential detox?
Do Joe want to go over the ASAM criteria for placement? Or usually when you do a thorough history, you try to go over different dimensions that are, biomedical, the readiness to change, like if there's a risk of withdrawal or intoxication, risk of relapse or continued use, and what the recovery environment is like. So we try to do those assessments and figure out, what's the safest, best way. Usually by the time they need to go to residential, they've already tried the outpatient, they've already tried some other treatments before you would consider that residential treatment. But and it's sometimes really hard to get placement, unfortunately, but it is doable. So Joe, do you have any?
Well, I mean, I think a lot of what any kind of residential program would be used for is for folks whose social situation is so impacted by use that they can't get away from it. And they don't respond, or they haven't had success with less intensive forms of treatment. Certainly not something, and detox is a funny term to use for residential. That's kind of a, detox, what I consider detox is like that first effort to get off, like going through a withdrawal syndrome. That doesn't need residential treatment. That needs something usually much briefer. That a hospital stay might be necessary, but we're not talking about a month, and it wouldn't necessarily be done in a residential program.
So here's a question about methadone clinics, and is there evidence that probably someone has raised this issue in the past? Is there evidence that methadone clinics contribute to crime or lower property values?
It's a good question. It comes up a lot, and definitely a big concern when methadone clinics are looking to expand or sort of be in new communities. I didn't know what the research behind this was, so I was just quickly looking that up. The quick answer is no. So there was a study that came out in 2019 from the National Economic Bureau, something like that, that showed that property rates did not decline in communities when a methadone clinic was established in that community. And then I was just looking around briefly and found there was a comparative analysis of methadone clinics, corner stores, convenience stores, I think one other thing in sort of urban places, and found that methadone clinics were no more likely than the other places to increase the crime rate, and were actually less likely to increase the crime rate compared to, it's similar as a liquor store and less frequent than convenience stores and corner stores. So this paper argues in their findings, and again, this is a really brief, I'm not quite sure sort of the full context of the paper, that liquor stores and methadone clinics were actually contributed the least to any kind of increase in crime rates.
And we know that methadone clinics, people who go to methadone clinics, their rate of crime goes way, way down. So for those individuals who are in treatment, the crime rate is, and return to jail and all those measures are reduced quite a lot.
Thanks, that's helpful. Now I've got a question and follow up to the question about prescribing Suboxone or methadone for chronic pain. What would you recommend to an older adult who's prescribed Suboxone for chronic pain, but it isn't working very well for that particular patient?
That's a good question. I feel like it gets at sort of a common and tricky scenario of like when someone's on prescribed opioids and they're not necessarily getting any functional benefit. And that can happen for Suboxone and for other opioids. I'm like, I'm the newest to practice here. And so I think like hearing that, like, I think for me, I can't imagine like trying a full agonist for chronic pain, like making that switch feels iffy, like if they're not getting any benefit from Suboxone because you're taking on so much more risk. And so I feel like it would be about trying to sort of optimize all the other modalities for treating pain, and really sort of like putting energy and focus there. Yeah, definitely curious, Adel and Joe, what you would do.
Yeah, I'll tell you, I think there's definitely that patient-centered care, harm reduction, trying to do the right thing, keeping in mind the risk and benefits. So I have done dealt with patients who I transitioned to Suboxone, and unfortunately they didn't do well. They just didn't work for them. Functionally, they weren't improving. There was really no benefit, and we still persisted, adjusting the dosing, how they're taking it. And these are patients where you would really want to document well and try to figure out, going back to the basics, like the functional status, what are you trying to achieve, how are they getting benefit. And I've had cases where I went back to opioid agonist after full lengthy discussions, and most of the time I was able to go down to a lower dose than what they were before, and considering to use the lowest possible dose that has the most effect and try to minimize the side effects. And at the same time, like what Mary mentioned, going on to use non-opioid treatments, and consider things like cognitive behavioral therapy, which has a lot of evidence for it. So maximize your non-opioid treatments. But yeah, there are cases, especially when you're a PCP, you work with them for a while, you can do these things if you're doing it safely and you're considering all the risk and benefits. It's possible to do so. Yeah.
Yeah, I've had similar experience where for the most part, people who've switched in my practice have done well, and they've really appreciated how stable it is. A lot of times with full agonist opioids, there's a lot of up and down in their pain control through the day, whereas buprenorphine is very stable. So they're not always thinking about it, and and they can participate in other kinds of care, which I think is important. The other thing is sometimes the dose isn't high enough. And so sometimes it is safe to increase the dose because it has that ceiling effect. But some people do better at a higher dose of buprenorphine, and I'd be much more likely to try that. But I have had people go back to full agonists, and again, at a lower dose, like Adel said, but mostly those patients have ended up on buprenorphine. They actually see that they're starting to have more craving. They're having not as consistent pain control.
So if you don't mind, I just have two more questions. I know we're a little bit over. One of them is, are you seeing higher rates of palliative care being issued for older adults with chronic pain, and any cultural differences for cultures that maybe are not fond of psychiatry or mental health as a treatment in those scenarios?
This isn't going to be like a perfect answer to that, but just sort of to share like a scenario that I think like covers those things and was like particularly distressing for the team all the teams that were taking care of this patient. I think that like one like big gap in palliative care is folks who are especially on methadone and are not yet hospice eligible. So like maybe, don't meet that 6-month criteria, like don't have sort of the prognosis is just a little bit longer than that, but they may still be like like not physically able to make it to a methadone clinic every day for dosing. And so oftentimes people can get take homes, but that's not true for every patient. And so there can be this group of patients who are not able to get to a methadone clinic, but also are not eligible for hospice to be prescribing their methadone. And then it's sort of this like really tricky place of technically like no outpatient prescriber can prescribe it for opioid use disorder. So can you argue that it's for pain? And it gets into this sort of really sticky area. So that's definitely something that like has come up as a particular gap in the sort of palliative care management of folks with opioid use disorder.
That's helpful. And then the last question, which actually could be a lecture in and of itself, and we do have an archived lecture on marijuana/cannabis in older adults, but anything you want to say about drug interactions or use of cannabis for chronic pain, these other kinds of disorders? I think it was mentioned early on.
Yeah, I guess I don't know that I have more or data about older adults in particular. When I talk to patients about cannabis, I try and because so many of them are using it for some kind of medical purpose, and that's what they interpret their use as. And I try and have them talk about how it helps them, and then also talk about any side effects, because a lot of times people don't think about that. Are they sedated? Are they less motivated? Are they less clear in their thinking? So just trying to, again, it's motivational interviewing. What are the pros? What are the cons? What do you want to do?
Okay, well, thank you. And thanks for staying a bit over. Great presentation, really helpful responses to questions. And I'll see everyone next week. Thanks so much.
Thank you all.
Thank you all. Thank you.